Thank you so much for joining this webinar. As mentioned, I'm Shobhit. I'm a PhD candidate at Tilburg University in the Netherlands. And this is my job market paper today that I'll be presenting. It's called The Effect of Initial Location Assignment on Healthcare Utilization of Refugees. Now, before I begin with explaining to you all the models and everything, let me start with just a few headlines. So I'm sure many of you might already know this, but migration is becoming a bigger problem day by day, with a lot of developed countries facing issues with how to curb migration, or rather, like many call them forced or illegal migrants. But it's not just from the side of providing services to the migrants, but it's also from the side of the migrants that the problem might arise, because they are a vulnerable group. They face a lot of health problems during their migration journey and even otherwise. So, in order to understand how, once they migrate to a developed country and they start to integrate into the society, what should be taken into consideration, or like the first step should be to understand what are the health implications of uh, of these migrants once they start to integrate into the new society. Uh, so building on this motivation, uh, I would like to start by presenting a few facts regarding how health might be affected. The first thing is that where we stay or where we reside, that has an important role to play in our health, as not just our health, but it has an implication on also the healthcare utilization. Uh, and uh, although there are papers that study the effect of the location on the labor market outcomes of the refugees, there are not that many papers that have actually looked at the health and healthcare utilization of refugees in this context, as to how the initial location to which these people are assigned that affects their health. And one thing to note here is that, unlike other immigrants or the native population, refugees do not have autonomy to choose where to reside. So it's mostly the government policies, also called as the dispersal policies, based on which they are allocated to different regions. And generally, they are allocated in such a way that there's a like homogeneous distribution across different regions, so that not one location has to face all the consequences of the migration, the migrant population. So, and as I already mentioned, they are a vulnerable group. They have traumatic experiences from their migration journey. So it becomes even more interesting to understand what are the health implications of the location to which they are assigned. Uh, so in this paper, I'm answering two main research questions. The first one is how this initial assignment affects refugees' healthcare utilization, and how much of the variation in healthcare utilization can be explained by just these location effects. And the second question is, if a refugee is assigned to a location or a municipality where the healthcare utilization among non-refugees is high, then how does it affect their own healthcare utilization? So the idea is to basically estimate a causal link between the location to which these individuals are assigned, and how does it have an impact on the healthcare utilization of refugees. And in order to understand this effect, I use three outcome variables. All three of them are healthcare utilization measures. So one is the hospital visits of these refugees. And I also look at their depression medication usage and general practitioner cost. And the idea to use these three outcome variables is mainly to understand the primary healthcare, how well the primary healthcare works, and whether they are able to understand the primary healthcare system of the country, and like, because that is the first thing that they would want to know once they start to integrate into the society. And then whether that has, and yeah, I mean, I because the first point of contact in most of the developed countries is the primary healthcare, and then if they get referred to by these primary healthcare providers, then only they visit the hospital. So that's why I'm focusing on just the primary healthcare provision. And the identification that I'm using in this paper is how the refugees, when they are assigned to these municipalities, that is independent of their health, uh, mostly healthcare utilization, conditional on obviously some of their demographics. So it's not perfectly random. You have to control for some demographics, and then it's conditional randomization across these municipalities. So before I jump into how this paper contributes to the literature, I would like to first mention some findings of the paper so that I can contextualize what's the contribution. Uh, what I find is that almost 10% of the total variation in hospital visits among the refugees can be just explained by these place effects. And the variation, the proportion is actually higher for depression medication usage and GP costs. I also find that refugees' healthcare utilization is higher in the regions where you have poor socioeconomic status and where you have better healthcare access. And also, the healthcare utilization is actually lower in the regions where the crime is high. So this actually is something to give or to provide some suggestive evidence on what are the plausible mechanisms that are driving these results. Then I also look at the heterogeneity among females and males, as well as children and adult population. And what I find is that the hospital visits and GP costs among females is higher in the most populated municipalities, and it's lower for the males. Although for depression medication usage, I find it the reverse. So the idea here is to just see whether all the locations are, or rather in this case, the top municipalities have a similar effect on both the population groups. And answering the second question of my paper is whether if a refugee is being sent to a municipality where the healthcare utilization among non-refugees is higher, whether it has an implication on their healthcare utilization. And what I find is that there is a positive and significant effect. So if a refugee is placed in a municipality where the healthcare utilization among non-refugees is higher, then their healthcare utilization also tend to increase. Uh, and this is to indicate that similar place effects are actually affecting both the population groups. So it's not like, so a priori, there's no hypothesis as to why should, if you are being sent to a municipality where the healthcare utilization among non-refugees is higher, then why should it has an effect on your healthcare utilization? Maybe so it can go both ways. One is that uh, just the location is worse. Like for example, there's high pollution, so healthcare utilization among non-refugees is also higher. And similarly, once you are assigned to that municipality, your healthcare utilization also increases. But it can also go the other way, because if there are some capacity constraints, there already is not enough space for non-refugees, then maybe you are not able to access all the healthcare services that are available. And so your healthcare utilization will actually go in reverse. There was no a priori hypothesis on that, but what I find is that it's actually the positive effect that comes out to be significant. And I will mention this later on why I feel that this is the case. So
Just
yeah. Yeah.
Can I jump in here? There's a quick framing question in the chat that I just wanted to raise since it's related
Uh-huh.
to framing. The question is, why do you frame it as the effect of location on health system rather than a policy question of does dispersal policy have consequences for the healthcare system?
Yeah, that's a great question. Thank you so much. So why am I framing it as a location question and not as a dispersal policy question is because I mean I could have done it both ways, but what I'm really interested is in understanding the location effects because location can directly has an influence on health, and that has been estimated to explain almost 50% of the variation in healthcare cost for the US, and a similar proportion is found in Germany and Netherlands as well. So across countries location and actually, okay, so maybe I can answer that question with this literature slide as well. So maybe I'll just continue with the literature slide. So the first question is exactly the dispersal policy question, which kind of I'm answering to. So my paper does relate to the effect of dispersal policy on healthcare utilization of refugees, and that's the first strand of literature um that I'm uh, that I'm contributing to, because people have looked at the effect of dispersal policy on, let's say, labor market outcomes, their cultural assimilation, education, and there's a very recent working paper which also looks at their long-term health. But but yeah, it's that, as I mentioned earlier, that this is a very understudied research question, and that's why I wanted to even explore this even further and understand how the location or the dispersal policy can actually impact the healthcare utilization of refugees as well. And then comes why location, and that is something that I'm more interested in, or rather, that is my main area of interest, is because there is a whole set of literature in health economics where they have mentioned that um, location can directly influence your health care costs, but at the same time, it can also affect your mortality. And this is something which is very hard to estimate how the location directly is causing is directly affecting your healthcare costs and mortality. Um Mainly because there are selection effects. So people choose where they want to stay, and so there's no clear way to disentangle these two mechanisms as whether it was a selection effect or whether it was the location that is affecting your health. And so these papers, they have actually looked at the movers approach, or in labor economics we call it the AKM model, and there they have used this approach to disentangle these two effects by using internal migration as an identification strategy to disentangle these two effects. And my paper contributes to this literature by just using a government policy, which is random assignment of these refugees in order to estimate these location effects. So that's why I mean, I'm focusing more on location, mainly because I want to basically contribute to this stand-up literature. I see a hand. Hey, Romy.
Right. Thank you very much, Rick. And it's really interesting. And I would like to ask you about the outcome variable. I understand your focus in the healthcare usage rather than the healthcare condition. However, I just wonder why you particularly focus on depression medication or prescription medication. I think you already mentioned about the refugee more likely to have the struggle for the mental issues. However, in taking into account the some countries, some cultures are hesitated to either taking a medication or mental health, the consultation or something. Probably in this case, the medication for the chronic condition will be helpful to capture at least indication of the actual the medication. The compare the gaps could be something like, you can say actually there might be unmet needs for the mental health, particularly this kind of stuff. And then, so just would like to add some comments on that.
Yeah,
Thank you.
thank you so much, Hiromi, and that's like an excellent question. So basically, you answered the question yourself. So the thing is, I'm using administrative data, so I do not have their health conditions per se, because that's like a very survey kind of questions. Although I do have a survey as well that was conducted, especially for these recent migrants. And there we see actually that almost 40% of the refugee group have mental health problems. Although, and I'll show you this in some later slides when I show you the data, only 4% of this population uses depression medication usage. So actually, the medication usage is very low as compared to the mental health problem that this population face. And as you answered, and you have already answered this, it's mainly because of stigma. And I've also talked to a couple of policy advisors at the municipality as well, and they have also mentioned that these people, they obviously there's a big stigma and they don't want to go to the general practitioner or other psychiatrist, mainly because they don't feel comfortable doing that. So one reason exactly to use depression medication usage is to see how much of this is still unmet, and whether they actually so the people who are using it, where they are using it, and what factors might be the reasons why they actually end up using depression medication usage. So I cannot make a causal claim there, but I can definitely know in which municipalities the usage of depression medication is actually higher. And then I can correlate them with some of these municipality characteristics, and I'm able to understand what are the factors that might be driving this higher usage. Yeah. Thank you so much.
Thank you very much.
Yeah. So I hope that I've answered why am I looking at location, mainly because I want to contribute to this literature, which basically struggles a lot. They make some very strong assumptions in order to explain how the location is affecting health. And I think my identification strategy does a good job in that regard. So before I begin with my data and model, I will start by explaining to you how does the asylum process work in the Netherlands. And then I will go to the data, and I will obviously test the identification assumption, because we as economists, we don't believe that the policy itself will be perfectly random. So we need some results. And that's why I will also test this identification assumption. And then I will answer the two questions that I have put on. The first one is whether location has an effect on this healthcare utilization, possibly explaining what are the mechanisms, maybe through some suggestive evidence, and then how does the effect how does the healthcare utilization of refugee gets affected when they are assigned to a municipality where the healthcare utilization is also high for non-refugees. So yeah, I'll start with explaining to you how this works. So in Netherlands, once an asylum seeker enters, they are first sent to this location, which is Ter Apel, and it's just like a officially they can stay there for 1 or 2 days, where they just uh, file for their application that they want to get asylum, and they're identified, the registration happens there, and then they are sent to these reception centers, because they are legally entitled to stay in these reception centers till a decision is made on their application and so on average, according to my data set, they stay there for 135 days. Once a positive decision is made, then they are sent to a municipality where they get the social housing, and then they can stay there for an indefinite time, because now they're currently they are status holders, or they have the resident status to reside in Netherlands. And then they can start integrating into the society. They can start working as well. So so basically there are two random assignments, and I want to clearly point out that I'm focusing on the second random assignment or not the first one. Because till this point they are still asylum seekers, they're not refugees yet. So only the people who get the resident status, they are called as refugees. And so I'm looking at this second random assignment. Uh, some more background. So the Dutch dispersal policy, it has not changed since 1995, and the idea of this policy is to spread the burden across the municipalities so that not one municipality has to face all the cost and provide all the accommodation to the refugees. Although they started to introduce some matching criteria, for example, they started to talk about their education and also their work experience, and if they have some family ties in the Netherlands. But housing is always prioritized, mainly because social housing in Netherlands is, yeah, it's very hard to find a social housing in Netherlands, and so it's always the moment you find availability, they are just sent to that location. So it's not like they have a choice. And some of you might think that obviously, since these people are coming from a different country, they must have some sort of medical assessment when they arrive in the Netherlands, and that actually happens. So when, as I mentioned, in this Terapel Center, they do have some medical assessment, but this information is not passed on to the people at these reception centers. And so because the decision on where to send them after their application gets a positive response to this municipality. So it's decided by the supervisor at the reception centers, and they do not use this information about the medical assessment that happened in this Terapel center. And obviously, it's not just quantitative work, but qualitative evidence also suggests that there is there's actually this assignment is purely random. Sometimes it might also happen that people from same family, first cousins, or maybe yeah, mostly first cousins, they are sent to different locations just because the housing was not available. So that has also happened. So this is from the policy side, which basically suggests that the assignment was random. But I will also show you that this assignment is indeed independent of healthcare utilization once I control for some of their demographics. And in order to do so, I first need to introduce you the data. Mm, so the data comes directly from the Statistics Netherlands, which is this is the administrative data from the municipality records, and also the health register. No, yeah, so the health registers, and also what kind of medication they use. So I have almost all the I have the information for almost the whole refugee population that arrived during this time, 2013 to 2016. And unlike many other studies in this literature who kind of assume that a person who's coming from, let's say, Syria during this time must have been an asylum seeker just because there was a war happening in Syria at that time. But that so they make an assumption on that this person is an asylum seeker or not. But for me, that's not a problem because this registered data all directly tells me whether the person was an asylum seeker or not. So I have that information directly from the data. I can follow them from where they are living. So I can basically follow their municipalities over time. I know from which country they're coming, what is the year of immigration, age, gender, education. And for health variables, I have hospital visits and diagnosis. And this I know like date wise. So I can basically see whether the person visited a hospital on a particular day and what was the diagnosis for when they visited the hospital. But for medication usage and GP cost, I only know the yearly information. So only yearly how much they have spent on GP, and GP being general practitioner, and whether the person used a specific medication in that year or not. So I don't even know the frequency. I just know whether they have consumed that medication or not. And as I mentioned, so I have information from 2013 to 2016. And in total, I have around 52,000 refugees. So just to show you how these people look like, so majority of them are males, because these are the first, the first ones to migrate, and fairly young. And I also mentioned this before. So for around 135 days, they stay in these reception centers. For education, almost 40% of the population, I do not know their education, but most of them are actually children and like really old population. So the people who are in the working age group, for them, mostly I know their education. 56% of them have just primary education, and then very few have secondary and tertiary education. A majority of them are Syrians, 60%, mainly because this time period coincides with the Syrian civil war, and so that's like the major population that I have in my data set. Now, to explain to you how I test my identification strategy, I need to first tell you so what is the information that I have. The first thing is I'm using basically the hospital visits during their time at the reception center in order to assess how much of healthcare they might need, and if they have a higher healthcare need, then whether they are assigned to a municipality where the healthcare facility is better. So that's kind of like how I'm going to test this assignment assumption. So before they are assigned, so this is the time when they are in the reception center. Almost 10% of the population visited hospital at least once. But once they are assigned to a municipality, this share goes up to 0.18. So basically 18% of the people visited hospital at least once. And here this is individual year pairs. So it's not just these many people, but also year wise. So that year, next year, and so on. And this I could do for a bigger share, mainly because I exactly know whether they visited hospital on a particular date. So I can know even in the same year whether they visited a hospital before their assignment or after their assignment. For depression medication usage and GP costs, I cannot do it because it's only annual data. So I don't know whether they spent this money before or after, or whether they used the medication before or after their assignment. So here, that's why the number actually falls, and it's only after their assignment from next year onwards, whether they use the medication and how much do they spend on GP. So this is mainly the data. And as going back to Hiromi's question, only 4% of these population use depression medication usage, although from what we have seen in the survey, the mental health problems is prevalent for almost 40% of the population. So yeah, there's already underutilization of this medication. Sorry, yeah. So now that I've explained to you about the data, I will jump into how do I test this identification assumption. I do it in two different ways, and mainly because I'm answering two different questions. The first question was, how does the municipality affects their healthcare utilization? And so what I want to test is whether when they were assigned to a municipality, that municipality cannot cannot explain their predicted healthcare utilization. So what I do here is I just use the hospital visits pre-assignment as the outcome variable, and I just regress it on a bunch of on the destination municipality dummies. And I do control for the municipality where they are coming from, their age, gender, and other demographics, and also the year of immigration. So conditional on two people who came in the same year, who look almost the same demographically, and who were in the same reception center, a person who went to a hospital should not be sent to a municipality where the healthcare utilization is higher as compared to the person who did not go to a hospital. So both of them should have same probability of being assigned to the same municipality, right? Just because one person was going to hospital a couple of times during their reception center time should not determine whether they are sent to another municipality. So what I really want to test is whether this is jointly significant or not. So that's the first.
Shobhit, you have 10 more minutes.
Okay. Okay.
Just giving you the time warning.
Yeah, okay, thank you. Okay, so this is the first way of doing it. And the second way is because I want to test whether the non-refugees healthcare utilization does not predict their own healthcare utilization. So here I use the average healthcare utilization of non-refugees in the destination municipality, and that I want to just see whether that does not predict their own uh, healthcare utilization. And since I do not have other, I cannot use other measures, I'm using hospital visits. So it's basically both the things are doing almost the same thing. One is I'm using municipality dummies, for other I'm using the rate of hospital visits among non-refugees. And these are the beautiful results that I find because all of them are insignificant. So as you can see, the p-value is quite high for the joint significance test, and at the same time, the rate of hospital visits among non-refugees is strongly non-correlated to the hospital visits among the refugees. And I use basically different measures to check this, that at least this result is robust, and I find that for every specification this is insignificant. So this gives me credibility that yeah, this assignment was indeed independent of their healthcare utilization. Now, coming to the results. So what I do is I just regress their healthcare utilization measure on municipality dummies because these are the location effects that I want to find. Also, obviously, I have to control for a bunch of demographic characteristics because I mean that these are the characteristics that I control for when I tested the assumption as well. So I just control for those characteristics. And this is the map that I find. So for you who are not familiar with Netherlands, this is how Netherlands look like. These are some like 380 municipalities. And as you can see, they are spread all across. So it's not like they are just, I mean, so the policy actually works well. So they are just spread all across the Netherlands. I must say this, that I have restricted only those municipalities where at least 20 people were assigned, because in order to get precise estimates, otherwise it's very small number. Now, some of you might be wondering whether these place effects for hospital, whether it's a good thing or a bad thing. I mean, it can be a good thing just because they are able to understand the system well, and so that's why they are visiting hospital. And but other thing also could be that they do not they're just facing more health problems, and that's why they're visiting hospital. So it can be both, whether these place effects are positive or negative. So that's why I look at two specific diagnoses. One is ambulatory case sensitive condition. These are those conditions for which you should not have visited hospital, but you ended up visiting hospital. So this can be, for example, diabetes. So the general practitioner at their level should have taken care of it, and you should not have gone to a hospital just to get diagnosed of diabetes. So that's one of those conditions. So this basically is an indication of whether the primary healthcare sector works well or not. And then the second one is emergency visits. So these are those hospital visits for which you have to go to a hospital. So the general practitioner cannot cannot, I mean, they will have to refer you to the hospital, or you have to just bypass the general practitioner. So this is like, for example, you're in an accident, you have a fracture, and you have to go to the hospital. So these are the two conditions that I look at just to understand whether these place effects are actually negative or not, in the sense that they are like if in a higher place effect actually means that it's negative or worse for the refugee. And what I see is actually it's there is a positive association between the overall hospital visit place effects. For example, I'll just show you one graph. So these are the place effects for hospital visits, and here I see the place effects for ambulatory case sensitive condition, and I see that, yeah, I mean, this is like a positive slope. So basically, the municipalities where there is higher place effect for hospital visits also have higher place effects for ambulatory case sensitive conditions, suggesting that these municipalities are actually bad for the refugee group. Then I can just because I have the place effect, I can estimate how much of the variation in hospital visits and for depression and general practitioner course, how much of it can be explained by this place effects. And what I see is that as I mentioned this before, 10% for hospital visits, 19%, almost 20% for GP costs, and 14% for depression medication. So actually, it explains a lot of the variation in healthcare utilization among the refugees. Now coming to mechanisms. So as I mentioned, there is a lot of literature on this in health economics, where they want to find out what are the plausible mechanisms through which a location might impact your health. And this paper, which was in Journal of Economic Perspectives, they basically provide 5 interlinked mechanisms through which location can affect health. So what I do is I basically come up with some measures of these mechanisms just to see which municipality characteristics are correlated with higher place effects. So yeah, I'm not going to focus too much on this, but yeah, so what I find here is that healthcare access, variables for healthcare access, for example, number of hospitals, number of general practitioners, they have a positive correlation with place effects for hospital visits, suggesting that if you are sent to a municipality where there are more number of hospitals or higher number of GPs, then you are more prone to visit a hospital. Uh, and actually it's the other way for distance to station. So if you are in a municipality which is quite rural and you do not have a good train connectivity, then you might end up not going to hospital that often, so to say. For depression medication usage, and this is something what I find interesting is that so having general practitioners or hospital is not that much correlated with the place effects for depression medication usage. Actually, the ones that come out to be significantly correlated are the ones which are related to socioeconomic status. For example, if the share of population who's living below social minimum is higher in a municipality, then you are more prone to take depression medication usage. And if you are in a municipality where the average income is lower, then you are more prone to use depression medication usage. So it's actually the socioeconomic status of the municipality that explains why you might end up using depression medication, and this can be directly coming from whether you are able to integrate into the labor market or not. Okay, so the second question and the last part of my slide is whether these place effects are similar for both the population groups, so refugees and non-refugees. So I just start by plotting a scatter plot where I have rate of hospital visits among non-refugees on x-axis and rate of hospital visits among refugees on y-axis. And I see, although I mean, like not that strong, but a positive correlation, which is actually significant. So this is just a correlation saying that the places where where non-refugees have higher healthcare utilization are also the municipalities where refugees have higher healthcare utilization, and this is average across all the whole year time period. So to go from correlation to causal, as I've already shown you that the rate of or healthcare utilization among non-refugees was not able to explain the assignment. So I can just estimate the healthcare utilization of refugees and I can just regress it on the average healthcare utilization of non-refugees for the same outcome variable, obviously controlling for the same controls that I had before. And what I see is that if you are sent to a municipality where hospital visits, depression medication usage, and GP cost is higher for non-refugees, then the refugees' healthcare utilization for the same measure or is also higher. So it's basically if a refugee is sent to a municipality with higher hospital visits among non-refugees, then they also have a higher chance of going to a hospital. And this shows that the location effects are affecting both the groups in a similar way. I did a bunch of robustness to be sure that this effect is indeed causal. And I can just skip this. So coming to the conclusion, there are three major findings of the paper. The first one is that the assigned municipality explains a significant share of regional variation in healthcare utilization among refugees. The location does have an effect, and it can also explain a sizable share of this variation. If a refugee is sent to a municipality where healthcare utilization among non-refugees is higher, then their healthcare utilization also increases, which suggests that there are similar location effects for both the population. So a priori, there was no hypothesis, but what I find is that it's a positive effect. And I do provide some suggestive evidence on it's the healthcare access for hospital admissions and socioeconomic status for depression medication usage that might be driving the results that we see here. And going back to the question that was asked in the beginning, whether this like how should I frame this? So although I frame it from location perspective, but this paper also adds to the literature on the effect of dispersal policy on how refugees integrate into the new society. And a bunch of future work that I have in mind, and this is for the job market, so I'm not going to discuss this here. Thank you so much.
Great. Thank you so much for your presentation. So now Ola Roman will give a discussion, and there are a couple of questions in the chat that we can ask afterwards as well.
Okay, can you all see my screen? Okay, let's see. All right, so just for the interest of time, I will skip summarizing the paper that we just saw. Let me just take a second though to talk about the strengths that I think that the paper has. First, I think that it's undeniable that the population that the Shobhit is studying is incredibly relevant. These people are in particularly extreme health conditions, both physically by the way that they had to do to get to the Netherlands in this case, but also mentally by the situation that they had to experience both in their countries of origin and the whole way. But not only that, this population, they also face higher barriers to access healthcare and healthcare services, both from the side of potentially being discriminated, but then they face other barriers such as language, etc. So he uses a very clean identification and answers a question that I believe is very, very relevant for policy. And I believe that this is something that would be great if you could really stress in your job market presentations. Given that right now, according to the World Bank, we're at a historical maximum of the number of forcibly displaced population, and that this trend is increasing given all the conflict that we have nowadays. Okay, so now let me start giving you the points of the discussion. So when starting your presentation and when I started reading your paper, the first thing that came to mind was how place effects could be related to health status per se. And then I saw in your last slide that you had a bullet point that you were planning on working on that, so I think that is great. So healthcare use and health, I believe, are going to be for sure correlated among each other. The question is, are there direct effects of location on health outcomes? The paper that you were mentioning before actually studies this and shows how physical health is affected in many, many different ways by the location where you are. I'm not going to go through them. I'm sure that you know them much better than I do. But what I was thinking about most, given the outcomes that you're using, is mental health. I was thinking that the place where you're going to be located is also going to affect how integrated you feel, your sense of belonging, whether you feel isolated or not. And this is going to have a huge impact on refugees particularly. So now the question is whether the fact that health is correlated with healthcare is going to be maybe problematic or something to think about a bit more deeply if we believe that place effects on health outcomes could be correlated with place effects on healthcare use. And that is something that would be nice to think a little bit more about and maybe discuss a little bit in the paper. And here I was just thinking of alternative maybe datasets in the Netherlands where you could actually look at these health effects. I found that there's this household survey, you probably know it, where they actually have some health data. So maybe some complementary analysis could be done to just look at health effects in each one of the municipalities. Then for the main analysis, your main finding, and I am taking this from your abstract, is that 10% of the total variation in hospital visits among refugees can be explained by municipality effect. And somehow in the paper, it's just one little sentence, and I think that it would be great if you could stress this a bit, because I think it's a result of high importance. And then something else that I found is that it was not super clear to me how you got to this number. It was not very clear if you had obtained this just by computing the variance of this place effect across all municipalities, or just by doing a variance decomposition, like AKM style, like you mentioned in the literature, right? I think that the advantages of doing like a fully fledged variance decomposition and giving it some more importance would be that you could compare it to the variation in your outcomes that can be explained by individual characteristics, for example, and could reinforce your own result. Then the part that I found most compelling is that you not only looked at place effects, but you also tried to disentangle what is in that black box, because we're not only interested in seeing whether location affects it, but we want to know how it does it. And you do it by correlating, let's say, your first stage place effects with a number of municipality characteristics. Something that I found is that now in the slides, you actually did it, but in the paper, I would have appreciated having like, okay, I'm going to measure healthcare access with this, and that, socioeconomic status with this and that. And particularly in this graph, it would be great if you could simply separate them. It would make it much more clear. I wanted to mention very briefly how you're measuring healthcare access, which is if I believe, with these two measures of the number of hospitals within 10 kilometers and the number of general practitioners. And then in thinking about this, I think that this is going to be correlated, for example, with municipality size. And I was wondering if there are other measures that you could construct that would be feasible to do, that would include some other considerations, like, for example, the per capita availability, if you would be able to, instead of simply having the number of GPs, if it could be possible to do something per capita within the municipality, or other sort of considerations, not only the number of hospitals within 10 kilometers, but also where the hospitals are located, if it's in the areas where refugees are normally located, or if it's in richer areas, for example. And well, this, I don't know if it's so visible, like some notion of the barriers that they could be facing. And then one last thing is that when you're doing this decomposition, what I was thinking is that many of these municipality characteristics could be correlated among each other. So instead of having these separate regressions, I was wondering what would happen if you just had them all together. I mean, I guess that the results could be looked at in a very similar way, and it would, alleviate some concerns about omitted variable bias, for example. And then, well, I had a couple of other comments, but about the black box of place effects. But let me just stress here that I think that with this detailed investigation of what is in the place effects, you could make much more detailed policy recommendations. And I really think that it would add value to the paper, which I think it's super interesting. And then I don't know how I'm doing with time. I'm rushing a little bit. I just had some other minor comments, mostly about the text, but maybe I can just share the commented text with you, and because there are some things about writing or something that I would like more clarity on, but maybe more personal. Yeah, in general, very good job. I like the paper a lot.
Awesome. Thank you so much for the discussion, Oluwatoyin. Shobhit, maybe you could respond to any point that you wanted for a quick minute, and then we'll ask the questions in the chat.
Yeah, thank you so much, all. I mean, all of the points were like really relevant, and I yeah, I must say I have thought about every point at some point during my yeah, I mean this whole, because at some point you have to just stop working on the paper because you need to go into the job market. So at some point I just stopped. But specifically 2 points that I would like to mention. One, doing everything together for the municipality characteristics. I did that, and I think that is also in the paper. Maybe not, maybe I just took it out at some point, but it was there at some point, and the idea, it was basically the same result. So I did not find any different results. So at some point I just thought, okay, I'll just keep the ones, because there is high correlation among high population, more number of hospitals, more GPs. So that's like, by default that will happen. So that's why at some point I just had one by one. And regarding the place effects of health and healthcare utilization, so that's a very tricky question. And that at some point my paper was titled "The Effect of Initial Location Assignment on Health of Refugees," and then after presenting it so many times, I finally uh, made it healthcare utilization, mainly because uh, in health literature, it's very hard to find a good measure of health. Mortality is considered to be one of the best ones, but because this is a very young population, I do not have that many people who might have died during this time frame. So I do not have a very good measure of health. And then I could have used survey data, as you also mentioned. There are surveys, and I have that data in my set, but there are two things. One, they're not representative at the municipality level, so I will have to go broader. And the second thing is, even though I try to do some correlation, but the sample size is so small that I did not find any precise estimate. So yeah, at some point I just gave up the idea of correlating this with health, and I just stuck with healthcare utilization. Yeah. But thank you so much, and please do share the slides with me.
Great. There's one question in the chat, which I can read out. It says, I imagine refugees migrating due to war might be more affected by things like PTSD. How can you ensure that the effect is not driven by the dispersal policy placing all those refugees from similar origin countries together in the same municipalities?
Yeah, I mean, that's also a very fair point. Thank you so much. So what I do have is, if they immigrated in the same time, they went to the same reception center, and they were almost the same age group, same gender, and coming from the same country. So after controlling for that, most likely they might have had similar PTSD problems. So I mean, I obviously, it's very individual, fixed effects kind of a thing that I do not have possibility of doing. But yeah, I mean, I do not mention this, and maybe I should in the paper, that is how this is like an assumption that after controlling for all that, this effect should be controlled.
Great.
Yeah.
Thanks. There's another question from Renee. Renee, you're welcome to unmute if you want to ask further. But the question was more along the lines of some of the mechanisms that were discussed, where the question was, do you know why places with more hospital visits would result in worse care for refugees? Is this because these are areas where residents are in general worse health or where there are more hospitals?
Yeah, so these are equilibrium effects, and I'm not so sure which effect is the dominating one. I mean, that's kind of a limitation of the paper that I cannot disentangle between the two, whether it's the healthcare access. So they have the possibility of to go to a hospital just because there are more hospitals, and so the constraints are not binding. Or it could be that just because in that location health on average is worse, and so that's why many people end up going to hospital. uh, so I do not have a very clear answer to that question, but what I find is, and through the GP cost, what I find is that these people generally they do not go to general practitioner and they try to go to hospital first. So they do not have very strong belief in the primary healthcare system, and that's what the literature has also shown. Uh, so I think that's why it's more about healthcare access story, because these people they generally tend to go to more. If they have access to healthcare, they will go for hospitals and not go to the GPs. So I think that might be one of the reasons, but obviously it's just speculation.
Thanks, Hiromi. Do you want to ask your question?
Thank you. I guess I should be rushed, but still, I have some question about the mechanism, and you already answered this question as well. But I just still wondering, is there any possibility to decompose the mechanism or the some factors of the municipality can be like using the blind Oaxaca one, or if you pick up some of the key main variable of the municipality and compare how the differences as well, and then we see how many which the factors are more dominant or something. And then also you also mentioned about the primary healthcare and the secondary healthcare as well. And then if you are focused on the people who already go to the GP and see how the many people go to the hospital, also the seeing how many the people using the healthcare, this kind of the step also the good to disentangle how they use it, that people use it, the healthcare services as well. And yeah, and also I think you in the paper you mentioned about you exclude the movers, the people who move the municipality after the initial location. But I just wonder if you are to pick up the movers and compare the healthcare usage before and after. Also, then use it as a robustness check. You may be saying like the same person, and also the change in the municipality, and see how the difference is also kind of the the factor of the location impacts. So I know this is too much, but if also this is possibly you can try after that as well. Thanks.
Yeah. No, I think all of the questions are very important and relevant. The first one, actually about the mechanisms, how to disentangle and how to go dive deep into the mechanisms thing. I did try doing it. I actually, so the GPs, and so this was on the appendix, but I did not show it. So one is that the places where they go more to hospital are also the places where they go less to the GP. So actually that is something that I do find, and this gives me an indication that these people they tend to use hospitals more than the general practitioners. And this is something which literature has also shown, just because they are not able to adapt to the new the primary healthcare system that most of these developed countries have. So I think, yeah, I mean that is, but still I do not think I can completely disentangle what are the main mechanisms. I do have an idea on how to look at the network effects, because in this data I do have their network and I can actually track who they becomes friends with or not over time. So that information is there, but that's something which I'll do in a different paper. So that's one. The second thing, which was about, sorry, I just blanked out. What was the second thing?
The second thing is it possible to decompose, like, I don't know, this is the one, and then I think, sorry, it's going to the focusing on movers.
Movers, yeah. So the
Yes.
movers thing, actually, I do have them in. So it's one of the subsection of my paper where I use the initial assignment as an instrument for their current municipality. So that's kind of like an IV regression that I do. Although, in order to understand how a specific location is affecting your health, and this goes back to Olart's point before that, it will take some time for the municipality to actually have an effect on you, right? So these people, if they move within like 5 or 6 months. So, and I'm looking at a very short duration of time. So I do not believe that, within 3 months they will have some effect of the location. So, and also, only 14% of the total population move after they are assigned. And out of those 14, 16%, and out of those 16, only 14% move within first year. So, and then they stay where they were assigned to, or at least where they moved to. So I don't think that their internal migration over time will have a effect in this short time or in this short duration, but over time these people move, and that is what I've seen from the historical data. So the refugees who entered in like 1995 and so on, those people are the ones who basically have moved over time, and then they just form clusters across Netherlands. So one of my research question, and that was on my job, like last slide, as a future research, was to understand how these people move once they integrate into the society, and why do they form such clusters over time. And that's, I think, a very interesting question. Thank you so much.